This morning's topic that we'll be talking about for the next hour is the possible trade-off between clinical quality improvement and cost. Does it save lives or does it just save money is usually the way I approach this question. Obviously, we're reversing that for this morning's session, and I think it's quite the change of pace for me looking at it from the administrator side. And with that, I'll be introducing the three panelists that we have to talk about their own quest in crossing that quality chasm. It's interesting that it's been almost 15 years since that seminal Institute of Medicine work has actually come out, and certainly been a profound impact on the way we approach quality improvement, and then thinking about it, can we also improve costs as well?
Good morning. My name is Terry Osborne, and I am the Medical Director for Quality for system quality at Spectrum Health System in Grand Rapids, Michigan. We're on the west side of the state, just north of Chicago, and I know the people out here are kind of don't know where we are, but you know we're on the mitten, so we got that. My job today really is in 7 minutes or less to talk about some of the trade-offs between quality and cost, particularly as it relates to the management of ambulatory anticoagulation. And my subtitle really is to bow to those who have helped me think about this problem, as well as some of the other professors we had in the program, so thank you for that. As a physician, I really wanted to start with the burning platform for me personally, just to put this in context and make it a little more relevant. In 2010, in my own practice, I'm an internist, I still work in the clinical care office. And in 2010, a 28-year-old mother walked into our office complaining of shortness of breath. Okay, pretty routine problem, except that she was a patient of one of my partners who had left the practice. And she was supposed to be taking Coumadin for a postpartum DVT. And when he left, there was nobody really to talk to. So she called, you know, you all know this, called the office, said, the provider had left, so the MA called and said, you're supposed to be taking your Coumadin. She didn't realize, she never answered, she got the message. And of course, the shortness of breath was a pretty significant pulmonary embolus. And she did fantastic. She did not die or any problem like that. But this was a trigger for me personally. Really, our whole organization saw this and said, boy, we dodged a bullet there. And what else is really going on? And maybe we better look at this problem. So the first thing we did, of course, like a good quality folks, are to do sort of a baseline assessment. And what we found in 2010 was the management, the delivery model for anticoagulation in ambulatory was really done ad hoc in physicians' offices. Really, basically, to be frank, off the side of the desk. Highly variable, unstructured, no way to track it, no standard reminders. Everybody did it their own way. In retrospect, we were not tracking TTR. Our process metric for Coumadin is TTR, time in therapeutic range. We weren't tracking it at that time. We really didn't have the ability to do that. But in retrospect, we were probably running at about a 45 or 50% compliance rate in our primary care. There is no national standard, but really you want to get that up to 66 or 70% if you can. So it was pretty poor. No quality metrics, of course, and the real important part for this discussion is there really wasn't any understanding of the cost. We weren't tracking costs. We weren't charging any. There was no claims. There was nothing really to track this population whatsoever. So in view of the case I discussed, the big question for us that are in quality and our providers and my team that I worked with was, how can we provide for our organization? At the time we had 30 primary care offices. We now have 51. How do we provide excellent care, the best in the country? Really, we were going for the best in the country for anticoagulation. How do we prove it? How do we monitor it? What can we do for everyone? And it really was an equity issue here. We didn't want to be treating patients separately at all, not by payer, not, nothing. And so how do we do this for everyone? And so that was really the burning question. So we went to the literature, looked at evidence-based best practice, and what we found was a lot of different things, of course, but the main thing we settled on was we thought the best way to do it was through a point of care, face-to-face clinic. But we also weren't sure, so we had a little bit of telephonic in there, and we had a nurse practitioner doing consultations in there, but we did get closer to standardized. So we were able to enroll about 1,800, 2,000, we got somewhere around in there about into this model of care. We got our standard algorithms, we got standard documentations, and we got our TTR that we could prove for those patients in the clinic up to about 66. We still weren't doing quality metrics, I'll explain that in a minute. About a year and a half, here's where the problem for this model was, is about a year and a half into the work, we discovered that we were already spending about $750,000 a year to support the clinic. That was the kind of the net operating costs. And this is where the finance people started getting kind of nervous. There were a lot of barriers, we can discuss those later, but they're like, okay, we've only got about a third, maybe a half of our patients in this model, and it's already costing us this much. Are we going to go up to 2 million, 3 million? Where does it stop? Because even though we were billing, I guess for those in the room, even though we were attempting to bill for the point of care clinic, that was kind of the trade-off. We thought we'll get some billing out of this. We won't just do it telephonically. Risk and compliance were not into that gig. And no offense, Jody, but we couldn't even get our claims dropped, and the documentation required was so draconian that we just couldn't pull it off. So we started to think about what could we do for everyone. Again, the equity issue, how can we make this the same for everyone? And really, we realized that we needed to become much more simplistic in our approach, very simple and efficient and clean design. We needed to get to more of a standardization, the focus factory. And then also we decided to basically opt out of insurance. Now, we probably have a discussion at the end about this, about what would we do about Medicaid or poor folks for this, but suffice it to say, we did not feel that we could provide this excellent care for everyone and work with insurance on it. So we subsequently converted that middle phase into a fully telephonic clinic, 24/7 RN directed. Everything standard. We had a process engineer design all our workflows. All our labs are flowing in into work queues that are being addressed by 11 RNs. We now have about 3,500 patients in the clinic. Our TTRs are still running 66 to 68%. We even hit 72 one month. We are reporting quality metrics, GI bleeds, intracranial bleeds, and pulmonary embolus. And most importantly, the actual contribution of the organization now, doubling the volume, is $670,000. So there's still a cost, but the organization is a lot more comfortable now at thinking, how can we get even more? And we have some ideas to make that even more efficient. I decided to actually show you the proof. So in front of you, I put the contribution statement. You can look at it and think about it for yourselves. We don't have time to go over it. But we're running this as a separate center and tracking it, and this will give us some real baseline stuff to work with as we move forward and really look at those actual costs. Now, total cost of care, we're not doing that yet, and we'll get to that at the end, but that's the next phase, figure out what it really costs. What about the complications that we can now track and see what kind of things are happening in that very distinct and identified population with those episodes. This is the first pass at our quality metrics. On the left is the number of patients that we've enrolled and the time frame. You can see we've been aggressively rolling in. We still have about another 1,000 patients to roll in, but we're really close. And on the right are the numbers of PEs, the control chart for the number of PEs that we're seeing in the population in the clinic. A lot of fun there. And this is what anticoagulation management at Spectrum Health looks like today. 2 of our nurses sitting in the clinic doing telephonic management. My manager took this picture. You can see how happy they are. I think that's what she wanted to convey in that. They work in a great place. And our nurses are recruited from the ICU, from other highly skilled nurses in the clinic. Some places use pharmacists, we use nurses. Lessons learned. Professor Shumsky, you're right. You got to have some process. Make it simple, make it easy, make it efficient, as well as John Cotter, all the change stuff. Everybody in the panel yesterday talked about all the things related to how do you make change stick, so I don't want to reiterate all that. There were 2 things for me that were critical just to share. First of all was this concept of evidence-based, and I think we saw it from the previous presenter. Okay, there is evidence, but when you try to implement in the field, how you get to that end game doesn't always line up with what the studies say. We could not, we tried our best, we could not operationalize a point of care clinic. It just didn't work in the field. So we had to go to our backup plan on that. And then the final thing I want to say is when you get in a change process, the most important thing to me is being able to tell a compelling story to all the stakeholders. And getting that story right, getting to the heart of helping patients really helped us get through some of the problems of operationalizing this clinic. So with that, I will turn it over to our next presenter.
Good morning, everybody. It's a pleasure to be here today. I was really thrilled to get the invitation to come up. I'm the Senior Vice President for Quality and Population Health at Baystate Health, which is about 100 miles down the road, literally on 91, and I'm a professor of medicine at Tufts University. And what I wanted to do is just share some work that we've done regarding quality and cost, with really a focus as a case study on our bundle payment work. So just first, for those of you who aren't familiar, Baystate Health is a 4-hospital health system. We have a large academic medical center, Baystate Medical Center, a large physician practice group, a health plan with about 200,000 covered lives, and a VNA and a physician practice group with about 600 employed physicians in Western Massachusetts. A few years ago, we really made a commitment that we were going to try to lead healthcare transformation. And as many of you know, Massachusetts started healthcare reform really in 2006 with the passage of a series of 4 different laws over the past 9 years to transform care. And we recognized that to do this right, we needed to actually take the lead as a provider or organization, and having a provider-sponsored health plan as well. We really felt that we were in the right position to be able to do this. So all of our language we began to transform around achieving the triple aim in our health system. We spent a lot of time talking about value and this idea that healthcare is in a place right now where we really don't understand the cost of care. As we began to really think about how we organize our healthcare system, looking at outcomes and costs, we realized we needed to do things differently. We needed to really begin to understand quality and cost for an entire episode or an entire condition. And I think our talk earlier this morning around oncology was a great illustration of that. But to do this, you really wanted to think through what is the unit of reimbursement and how that unit of reimbursement needs to be aligned with this unit of value. Healthcare is probably the only industry that we can think of that we really don't understand all the costs. And in fact, when you see a patient undergoing numerous procedures, x-rays, laboratory, physician visits, hospitalizations, the number of bills that are generated from a single episode is overwhelming, and almost makes it impossible for us to understand the costs of that entire episode. So along came this concept of bundled care. With our health plan, we realized we had a great opportunity to take episodes of care, define what episodes were, and then integrate a payment model that was aligned with an episode of care. Our goal was really to redesign all the systems into an evidence-based practice and then tie the reimbursement to the episode of care. The ultimate goal was really to bring together all the interests of the patient and the provider and the payer, in this case our own health plan, to focus in on the episode of care, and that really was our bundle payment concept. It required doing 3 things that we had never really done in organized fashion. The first was we needed a new care model. And we needed to have leaders and clinical leaders define what is that new care model. We obviously were creating a new payment model, in this case a single payment for an episode of care. And then finally, we needed a new operating model to do this, how we organized the healthcare system itself in terms of our leadership and how we collected our data and how we managed these patients. So it was really these 3 we pulled together to create our initial bundle payment work. Our principles were pretty simple. We were going to define an episode of care. We were going to create a single payment for that. We were going to reward only acceptable outcomes. Anything that was a complication essentially would be cared for without charge. And then we would allow our physicians to participate in a shared savings model that any savings from the set bundle price, they would be able to recoup, really forcing the idea of redesigning care to achieve the highest outcomes at lower costs. All this was to be done in a retrospective manner. So we would actually pay throughout the year on a fee-for-service basis, and then we would reconcile at the end of the year of how well people did. We pulled together, in this case, our first was a bundle for our total hip replacement and total knee replacements. We actually had our orthopedic surgeons who were not employed. They were actually independent physicians working with our health system. Our health plan and the hospital itself, we formed this collaborative and then began to recreate that payment model, that care model, and the operating model to achieve this. The changes were really dramatic in what resulted. And in fact, I will say that bundle payments themselves was the first time that I saw this conversation begin with providers and payers together thinking about the outcomes of care. It really changed the conversation of how we should care for patients. In this case, this was sort of what happened before. A typical referral to orthopedics would take place. The orthopedic docs would take care of the patients. They would have surgery. The patients would then go to usually rehabilitation, either at home or in a skilled nursing facility. And this has been going on for a long time. And there was really no understanding of any of the costs anywhere in this little cycle which had been created. The docs just did their job and made the referrals, and most everything in terms of costs was just sort of a black box. Once we started sharing all the costs of care and we started actually looking at the outcomes of care, we could actually begin the conversation. Well, what resulted was a very dramatic change. For one thing, the orthopedic surgeon said, you know, a lot of these patients come to see us and they're incredibly debilitated, they're very weak. You know, if we could strengthen them before they actually had their surgery, our outcomes would be so much better, but no one's ever paid us that way before. And so under a bundle payment program, they really had the ability to redesign the care. So after the orthopedic evaluation, patients had prehab. That really changed dramatically how they thought about the patients after they received the surgery. And actually, patients actually received a compact, which they actually had to sign on what they were agreeing to do in terms of the prehab as well as post-op. The patients would then either be going home or to a skilled nursing facility. The difference this time is that if they went to either home or to a skilled nursing facility, the physicians actually created a pathway for what rehab should look like. They suddenly were very interested in what happens in these nursing homes. They had no idea before. It was just, that wasn't their business. But suddenly, when they were responsible for the entire episode of care, and this includes up to 90 days after the surgery, they became very interested in changing what happened in the nursing home, making sure there were pathways and communication vehicles that never existed. So basically, what we did was we created this shared savings model where if we could beat our target price, in this case it was $24,600, and we redesigned the care from what you see on the top to what you see on the bottom, we would share the savings with the physicians and the hospital and the visiting nurse associations since they played a significant role. I think the biggest thing here was trying to keep patients at home, having them go prehab, not rehab, and then having agreed upon protocols. The results, this has been going on now for about 4 years. There have been very significant improvements, both in terms of the outcomes, and these are some of the typical outcomes that we tracked. Readmission rates, with the percent of patients going home, you can see went from about 45% to 80%. and tracking complications, typical measures for quality around surgical care, and then you can see the price overall for the bundle came down by about $1,300 with the HCAHPS as our measurement of patient experience also improving, which was really a tribute to the compact and the education. So this was just a wonderful way for us to sort of package together our managing a patient population, engaging our physicians, and using data to help drive the conversation. What goes into the bundle is, I think, one of the more difficult conversations to have. There's lots of things you can sort of exclude if you want. In this case, we actually included most everything, but you have to think about, is anesthesia in the bundle, is radiology, any other ancillary services. The more comprehensive it is, you have to engage more people in the process, but actually managing the politics through transparency, having the data, and having everyone come together was something that we found to be successful. I think this was a big step for our health system to really advance us towards achieving the triple aim, and by having measures in all three components of that triple aim allowed us to really advance the thinking around quality and cost.
Thank you for inviting me to speak. I am George Blake. I'm the Chief Quality Officer and Value Officer at Dartmouth, and a member, like Terry, of the class of 15. So in terms of, you've heard about an ambulatory example with a focus on chronic disease management, Coumadin management of people at risk. You've heard about a surgical episode of care. We wanted to give you 3 examples, and so I said, okay, I'll pick off a hospital-based acute episode of care, something unpredictable. So along the same lines, I'll spare you the strategy, but basically we start with value, but then I'll emphasize whether you make money or not. Boy, I tell you, if anything I've learned from hundreds of projects, you don't know. And I'll challenge you to predict what might be the case with sepsis. But I think these are the fundamentals we're all doing. And finally, the population management is about, when you're taking risk, managing the actuarial risk, having big enough numbers. You've already heard in the last 2 days how one outlier patient can have such an impact given the payment model you're in. So why sepsis? Huge number of admissions per year, 20% of ICU and up to 50% of ICU deaths. I believe it's running around the 9th leading cause of death in the US. Highest cost DRG for us at Dartmouth as well, and many of you. And an hour delay in the sick ones of getting antibiotics, broad spectrum antibiotics, confers an 8% increased mortality risk. So if you don't pick it up early and treat it aggressively, you have a bad outcome. It doesn't mean it happens always quickly, but you lead to multi-system organ failure, etc. So sepsis, overwhelming infection, that can lead to multi-system organ failure and death, typically in ICU, protracted course. It's great to be part of a collaborative, and in this case we did the recent sepsis work I'm going to talk about in 2014 with the National High Value Healthcare Collaborative that many of you participate in. We did a bunch of stuff. All the usual things. We at Dartmouth use a hybrid tool called DH-DMAIC. We like the acronym, but it's really a combination of microsystems, Lean, Six Sigma, Baldrige, sort of the best of the best. But define, measure, analyze, improve, control. And I would argue when it really comes down to it, we engaged folks, we gave them timely feedback of actionable data, and we gave them assistance at the elbow on how to redesign their system to get high reliability. Well, 4 things 2 that are towards early detection and diagnosis, 2 that are around rapid treatment with antibiotics and fluids. Those are the 4 elements of the bundle. When we started, the number of patients that were getting all 4 elements was about 6%. All right. Over the course of a year, and really some very rapid improvement in 1 quarter, we were able to bring that up to this level such that only 1 in 10, and this isn't so easy if you don't know exactly when the clock starts. But if you take initially patients who came through the emergency room and the ICU, these patients, we had a pretty good idea of what time 0 was, and we feel pretty good with our ability to improve this. This is what we did to our mortality. On the left side, percent, we started at around 50% mortality. I was a little embarrassed. I didn't appreciate with some of the data we already had where we stood against some national comparisons. It was very helpful to have the kind of data that we were getting. It was really a different view from the High Value Collaborative. It was very helpful. You know, numbers are not the reality. For us, when you turn this into the absolute impact, had we stayed at the mortality rate that we were at the end of 13 through 14, about 21 patients would have died that didn't. And if we stay where we're at now, going into this calendar year, that's 43 individuals.
The Cello Sonata Number 1 of Johann.
You know, I think measuring what matters, survival's one thing. It's certainly an important thing, but there's so much more. The ability to come back to work. It's kind of hard to look at an acute episode like this and value the person who lived versus the person who died, and all these other things that go to the care process and their experience, as well as whether they sustained that. You know, we know that some patients who, even if they live, have permanent kidney failure and end up on dialysis, et cetera. So I just want to emphasize, while I'm talking about something like mortality, there's so much more that we try to understand. And it turns out that Kathy is a colleague I've worked with in pre-admission testing as an anesthesiologist over about 10 years, who was one of those in 14 impacted by this work. Would she have lived or not? She certainly was in the severe sepsis category. She had shock, she had a protracted course, but this is her, after all that, on the day the Patriots won the Super Bowl. And it's a reminder for me, you know, of all those other things that we don't measure. Well, we were delighted to see some quick data we could pull from sort of our Medicare data set suggesting that there would be a real savings. But again, I've learned some lessons about really getting under the hood and seeing what the real financials are, and so this is great. It's nice to see. If we believe this, that's $50,000 less per patient, and you know, projected, again, looking at the before-after, that could be a couple million for those 43 patients. Look at this list. This is the last quarter of the actual patients. Now, net revenue, not a horrible number, and frankly, you know, we've had our CFO, COO have said, you know, there's times when we're in fixed cost and every patient we see, we're really seeing the incremental revenue. So because of so many fixed costs, you know, now if you're diverting patients who are elective surgery instead of these patients, obviously there's an opportunity cost. But as a way to tee up the discussion and sort of conclude my talk and get into the panel discussion, this is really meant to be food for thought about the reality that you often don't know. And in the end, I think where we're at today at Dartmouth, you could argue that some of this is, if there's a negative, it's the opportunity costs. of having to fill up the ICU and this. And I think one last point I would make, we pulled out the patients who lived and the patients who died. What do you think the data shows? Do you make more money on people who die or people who live?
Died.
All the ones we made money on died. So our payment models aren't there. People like Rob, United Healthcare, everyone's going to help us come up with innovative payment models where we can really incent that quality, value, saving lives does line up with a way to be incented. And it's why we need to change and move to partial capital, the various things, carve-outs, the things where we start to really understand what quality care looks like and how to properly set up a reimbursement system that makes sense and is sustainable. So I'll ask my colleagues to join me up here and I guess turn that on. Thanks.